speaker is Dr. Goh Han Leong. He is the Senior Principal Specialist at IHiS, which is the Integrated Health Information Systems, the technology agency for Singapore's public healthcare sector. So at IHiS, Dr. Goh leads the development of AI and data analytics solutions that can be used to better manage and improve healthcare services. So without further ado, Dr. Goh.
Thank you, Dr. Shalin, and great to meet you all today. Okay, I will just give a very brief introduction about IHiS so that you all know what are the business we are doing it. We are actually a national government agency, national health tech agency that serves the MOH as well as the public hospital institution itself. Okay, our work is quite diverse. We are not only doing with data, but more importantly about the technology that can help to improve the productivity as well as giving insights to the clinician itself. So this is just some of the illustration of some of the key area IHiS is involved in. It can be telematics, it can be IoT, it can be mobile devices as well. So today, right, I will just give a quick overview on what are the healthcare analytics that we are focusing on. For one good purpose as well, it's a pleasure to meet all the brilliant minds today here. And some of the problems that we are tackling is still outstanding. So if you have good solution, do approach me and also do private message me on this. So for the past few years, we know that actually there's a few events happen, especially in Singapore. We see that there are three key things that is happening. One is, of course, silver tsunami itself, that aging population. As the population age changes, the healthcare issue also changes. Previously, it may be more of acute care that we are going to take care of, but now will be more like chronic diseases that is bothering the whole population itself. And of course, we know that last year, there's a big launch of Healthier at SG, which is very much as a population health. And there's many ways that technology and data can bring to work in this area itself. And of course, for the past few years, we are being troubled by COVID itself. This pandemic have bring a lot of change to healthcare. In a very positive notes, this pandemic also open up a lot of so-called technology opportunity and also acceptance of clinician as well as policymaker towards data as well as technology itself, because nobody really know what to do there. So everybody was on a fresh page and everybody is very acceptance to a good validation and experimentation. Same thing, just a quick overview, how we perceive the use of health tech that will be useful. First, of course, is the early stage of detection and prevention. Nothing beats better that things don't deteriorate. So if we keep things at bay, mitigation of deterioration of patient will be very helpful itself. So in IHiS, we help to deploy Senina Plus that have been done by NUS as well as SIDPR, who are doing this AI for health screening itself. So we help them to deploy it. And in our own pipeline, as the second speaker, Dr. Joyce, have mentioned, diabetes is a key issue in Singapore itself. So we have done the National Diabetics Registry. With that, it opened up new doors as well as ability to use it for prediction of CKD. The other things that we think is very important is that how can we target correct treatment to the correct diseases, because we all know that each patient is unique by itself. So with targeted treatment, things will be better. And also that we have limited resources. With limited resources, it will be better if things are channeled correctly to the different patient. So we have a few of these things that is happening here. So it's the prediction of hospital readmission, or rather it's a high risk of multiple readmission, because we want to give the doctors much more runway to do the treatment or the intervention, as well as the care team to do home visit for them. And thirdly, one of the area that usually maybe I would say that is currently now surfacing is how can we optimize the limited resources that we have in the healthcare itself. And of course, that will be the command and control center. This terminology is commonly used in defense or even the transportation. But now we are adopting ideas at how we can smoothen the hospital operation with all these technology that have been built elsewhere and bringing it like video analytics as well as graph analytics. I will talk a little bit more about it later. But back to the focus of today's presentation is that I want to share the experience that we have in using machine learning in our fight with COVID itself. And these are some of the things that IHiS has done at the early stage of the onset of the pandemic. And one of the key things is on the patient care, which is very nicely, we have a good collaboration with CGH, with Dr. Charlene teams in coming up with this machine learning that can be used on medical images itself. And of course, I'm being lazy, as also I will not be explained as well as our both Qualcomm side have put in the video itself. I will just give this video presentation and I'll come back to that.
Community Acquired Pneumonia, CAP, is the leading cause of morbidity and mortality worldwide. To aid clinicians in decision-making, we built an AI prognostic model that can help doctors determine the likelihood of mild or severe pneumonia. Such a model could be applied to COVID-19 pneumonia as well. We call it the Community Acquired Pneumonia, or COVID-19 Predictive Engine, CAPE. Why is CAPE useful? It serves as a decision support for doctors, or in certain cases, even bringing out insights that doctors might have missed. In off-peak periods where a radiologist is not on duty, it gives doctors a first report. This improves patient triaging, leading to more timely treatment, potentially preventing or mitigating a patient's likelihood of deterioration. How does the model work? By combining historical electronic medical record, EMR, with chest X-ray images, the engine predicts the likelihood of a patient being discharged in 2 days, differentiating between mild and serious disease severity. This helps with prioritization of clinical work lists. When the AI predicts a high-risk prognosis, more medical attention can be channeled to these patients. It also provides an early alert on deteriorating patients. For ease of implementation, CAPE is incorporated into the radiology workflow as an AI-powered application. Model architecture. Prediction module of CAPE uses exception as a base model. We apply transfer learning by freezing the weights of the first 12 blocks and training only the last 2 blocks. This allows the network to apply the generic features learned and learn features specific to chest X-rays. Finally, global average pooling was applied before a fully connected layer was added. We then concatenate this layer with another fully connected layer encoding EMR. This is followed by 2 dense layers, and finally an output layer for binary classification. This is the architecture of the base model exception. To use CAPE, the physician first has to load the chest X-ray in DICOM format. Once loaded, the main page will display 3 main panels, predictive model outputs. The goal of this panel is to provide explainability to the CXR and EMR models. Patient attributes provides contextual information on the patient. Predictions displays the predictions and risk scores for each of the outcomes, and a visual indicator of high risk versus low risk. The threshold for high risk is adjustable and is currently set to 60%. Report template displays a configurable text report that facilitates copy-pasting into other applications for reporting purposes. This is a case study of a 42-year-old man with a positive RT-PCR test for COVID-19. CAPE calculated that the likelihood of his condition needing a stay of more than 2 days is 80.6%, indicating that his disease is not likely to be mild. The man was subsequently admitted to ICU for deteriorating oxygen saturation. To ensure its generalizability, we aim to validate the same model at other tertiary healthcare institutions. Hence, we are calling for collaborators and researchers to further enhance this AI solution with us.
Okay, thanks for that. So that is the overview of CAPE itself, and of course, in doing that, there's a lot of system integration and technology engineering behind it, especially as we need to work with the established healthcare system itself, like RIS-PACS system. But that will not be the key topic of today's discussion. More importantly, we want to share that CAPE itself, right, actually there's a tree model. We want to know that when the patient potentially come with COVID or pneumonia type of condition, what is their likely patient outcome? Could it be they face mortality risk during their inpatient visit, or would they end up with ICU, or is it a mild situation that they can discharge probably within 2 days itself? So that is in short the purpose of CAPE, to help as a safety net for the clinician or radiologist to capture the patient, as well as helping hospital resource planning. In the area of analytics, right, we just summarized these 3 areas that what we think works well in CAPE itself. So there's a few like things we publish in the different paper, like transfer learning, explainability, as well as ensembling it for structured and the unstructured image data itself. As Dr. Liu have mentioned itself, actually in healthcare, black box, there's very low chance that it will ultimately get deployed, because same thing, clinician is ultimately hold at the point of, in terms of regulation, what decision they make itself. So we focus on the explainability part of it, and of course this is a common terminology, the XAI itself. There is, of course, a lot of algorithms, a lot of tools out there that can help to do image explainability. But what we found is that there's a situation like no free lunch theorem. There is no one type of image interpretation algorithm that will work best in all cases itself. So there must be a standardized form of how they are tested, and which type of interpretation method shall we use for different use case. That's why the team encountering this problem statement came out with this framework itself. I will go into illustration a little bit further. So it's a combination of quantitative assessment as well as, of course, qualitative assessment. So there are 3 parts of it in essence. Of course, when we do the decision impact ratio, what it means is that if this interpretation model mark out areas that actually highlight to them to give the label output, if we take it up, how will the decision be impacted? Will they suddenly say that they are not so-called at risk of certain thing? The other thing is, of course, confidence impact ratio, like doing the same thing. What will be the change of risk score itself? So that will be the quantitative assessment we are talking about. And of course, the localized effect, which is the common matrices, like what will be the recall overlap with a clinician view that this patient actually have some condition itself. So that will be a good standard way of doing it in terms of recall, precision, as also IOU itself. So that is the 2 parts of the quantitative analysis. The other one, which is ultimately most important, is that do the clinician align with the reported outcome of the AI? What will be the trust of the radiologist? How will they see it? Which interpretation model suit them best? So that will be the 3 parts. And glad to share is that we have a so-called incidental finding when we try to do this exercise. So with a good panel of radiologists led by Dr. Charlene, we discover one thing that is incidental, is that when the clinician go through these different algorithm with us, they found that strangely, things like GradCam and shape have quite aligned to them, but in a different way. They are highlighting different parts, but they quite agree with it, and there's a good overlap of it. So we take the good convention knowledge of ensemble and see how can we merge them together. And by merging them, ultimately the outcome is actually quite good, I would say. So this is the paper we published. So the result is there. So when we compare with the different features of the image interpretation, that give us the most optimal result based on the 3 assessments I just now shared. And of course, on further thought of it, we will have thought that it makes sense because like CAM or GradCAM++ is bringing out the features of the neural network itself. While things like shape as well as line, they are a little bit brute force. They are agnostic to the model. They just cut up the image in a different way and drop it and see what is the performance changes. So it's a good complement to put vastly 2 diverse type of interpretation method together itself. And that is one of the key findings that we have in this paper that was published in the IEEE. And now I think in condition of time, I still want to go through with this, but bear with me for probably 5 minutes. I want to share journey learning forward. It's of course things that when we want to do deployment of model, it's never easy. We need a whole suite of people coming together, health informatics folks who is able to do the good, correct evaluation. Of course, data scientists, and of course, clinician itself who will give very good domain knowledge, as well as many other folks to come in as the whole team. And of course, same thing, we have been finding it quite useful to do all this design thinking and to share a bit more. During COVID, all this development was done within 3 months, and the whole thing was validated in 6 months' time. And all this is because of the good collaboration between the clinical team as well as the technology team itself. And of course, sustainability. The MLOps is what have been taking place in the past 1 or 2 years itself in the AI and analytics, especially in healthcare, because it's not just a one-time thing we deploy and we are happy with it. Data changes, we need to be aware of it, how we can make it sustainable, how when things change, there's a data drift, people are able to know quickly and do the necessary correction about that. Same thing, AI cannot take the center stage. We do a lot of software engineering into our deployment or the application itself because nobody really want to just use the machine learning outcome as it is or amazed by it. Patient want to get well, the clinician just want to have a good insights and able to do their job well. So it must be into their workflow itself. So that is some of the things to go for. And look, moving forward, right, really hope to work with many of the brilliant minds here because we have outstanding so-called problem. I just want to spend 2 more minutes to illustrate about it. One is graph analytics itself. It has been very useful so-called in the logistic area as well as the recommendation engine for e-retailers. We are finding it useful as well because it helps to bring the relationship between the data itself. We are experimenting with it, so we hope that on top of the conventional machine learning or even the deep neural network, we are able to do something like graph neural network analysis itself. So that is one of the open questions we are looking ahead. Another one is video analytics, ambient sensing itself. Video have become an eye in a lot of good work. And there's an outstanding problem. Of course, here I illustrate is like crowd management in the hospital, but there is more use, for example, like caretaking, medication compliance. It will be a good use of ambient sensing. We are moving into this area, so if there's good solution, please forward and talk about it. And of course, lastly, throughout the years, the whole team started in probably 2015. That amount of years, we have done quite a number of models. And when we know that when every time we need to do model, we need to do a lot of data extraction. And this is a very tiring cleaning up and also a very resource-intensive exercise. And of course, we know there is good thought on having foundational model starting from the NLP area, but we think that there are more of it. People are now talking about foundation model in image area, and of course, looking forward, we hope that we can do something similar for the structured data space as well. So there are the 3 areas that probably we will need help if you have the expertise in this, and do look forward. And lastly, you all know Healthier SG, there is a good things of population health, and there is this P4 health that is possibly in, that is coming up. So there is this journal that together with some prof in NUS, SMU, as well as HPB, we come together to have this journal. So if you are interested, do help to click and bring forward your idea. We hope to proliferate your idea further from here. So that's end of presentation. Thank you so much.